started. I don't see Lisa is not on yet.
I can introduce.
Okay, great. Okay.
Okay.
We're just going to go ahead and record. So, and then we can get going.
Okay.
Thank you.
Thank you, everybody. We've had a series of presentations over the last couple of months whereby we revisit our wonderful shared resources and provide updates about technology services, instruction, and outreach. By way of reminder or re-reminder, our Cancer Center has the honor of overseeing or participating in the implementation of 8 shared resources. There are certain shared resources that are independent of the Cancer Center, and they're based at the medical school or other parts of the university. So today we'll hear about, absolutely stellar molecular pathology shared resource and the integration of the human immune monitoring core, an integration that occurred about a year and a half, or about a year and a half or 2 years ago. So this is led by Dr. Hanina Hipshush, professor of pathology and cell biology, world leader in breast cancer pathology, and has done a great job in the innovation for the molecular pathology shared resource. And Dr. Ben Izar, who's an endowed associate professor of medicine and hemonc, world leader in melanoma biology and immunobiology. And he'll speak then about the human immune monitoring core. So Hanina and Ben, thank you so much. And Hanina, I think you'll be starting first.
Thank you. Thank you, everyone. So I'd like to talk to you a little bit about and describe the molecular pathology shared resource. The main mission of this shared resource is to support tissue-based cancer research. We do this with approximately 20 full-time employees with amazing managers like Kevin Dajang-San, as well as Tao Su, as well as Pareen Shah. And of course, with amazing partnership now with the Human Immune Monitoring Core with Ben Izar. Our facility supports tissue-based cancer research. In so doing, we interact with the 8 other shared resources of HICC, and we also interact with entities like the Columbia University Biobank, as well as Bridge, which is basically a bank for liquids, which stands for Biobank Resource for Investigating Disease Genes in the Environment. Now, broadly speaking, the way to describe the activities that go on in this bank is in these 4 bins. The first is that, broadly, we provide A to Z platform, series of platforms, and together one holistic platform for the acquisition, the processing, and the analysis of tissues, both cancer and non-cancerous, in an integrated manner that provides multiple services, provides expertise, provides material, like tissues, and provides data. And this covers the spectrum of having a bin relating to tissue acquisition, which includes both the traditional tumor bank, in which in the Department of Pathology, specimens that are collected as products of surgical resections of tumor normal, usually pairs. This is sort of what we call a population level bank, meaning that approximately 80% of tumors could be collected in this environment where we automatically collect tumor normal pairs and put them in the bank. In addition to that, a tissue acquisition arm includes the capacity to specifically respond to needs, a bespoke sort of banking of researchers, which is referred to it as patient-specific or project-specific banking. This means that if you as a researcher is interested in us collecting a particular case, either coming from the operating room or coming from any procedure done in the hospital, including interventional radiology, endoscopy, cystoscopy, bedside. You can send us an email with an RB and patient consent typically, and we will specifically collect in the manner and priority that you want a particular patient. This satisfies a lot of specific collection needs, also satisfies a lot of biospecimen collections for clinical trials. Of course, we operate on researchers' tissues that may be available from a variety of either external human tissue or much more commonly from experimental animals. And now we also interact with the Department of Pathology that has the largest archives of tissues, and that's the formalin-fixed, paraffin-embedded tissues that are part of the clinical services that are generated in the diagnosing of patients at Columbia University Medical Center. And we access those tissues under controlled environments and then process them and characterize them and analyze them as requested. In so doing, we integrate our activity with the Columbia University Biobank and allow us to determine whether we have frozen or paraffin or formalin-fixed tissue, whether there's corresponding blood or urine or other liquids that have been captured as a part of our GRIDGE, this biobank resource for investigating disease genes in the environment. And this is a very large facility that is able to can collect hundreds of thousands of specimens a year, primarily blood, but not exclusively blood, and other liquids. So that in essence, somebody can operate on any number of tissue types as well as corresponding blood and or other liquids. In the processing, we run a routine histology laboratory that covers an A to Z histology needs. And that includes everything from grossing, processing, bedding, sectioning, and staining. We make tissue microarrays, a massive variety of tissue types or tumor types into a smaller set of blocks to make things, screening things and analyzing things more efficiently. We macro and micro dissect specimen, not laser capture, which is done on the confocal microscopy. We extract DNA and RNA and determine quality. In the characterization arm, we have dedicated pathologists for slide review, both the facility pathologists as well as our affiliates in the Department of Pathology, review of immunohistochemistry and immunofluorescent studies. We have a dedicated laboratory for immunohistochemistry and using automated and non-automated capabilities. We have the BondRx autostainer for single or double staining for immunohistochemistry. Multiplexing here is available through the HIMC. We have a digitalization service using the Leica Aperio 82 system that allows us to digitize slides, provide analysis software, and we're closely integrated with the Department of Pathology Digital and Computation Pathology Laboratory that can afford development of, allow for the development of all kinds of algorithms to specifically identify subcellular components for digital characterization. We, as mentioned, DNA and RNA, provide DNA and RNA extraction from formalin and frozen tissue from our tissue acquisition arms. We also do next generation banking, which is the interrogation of the specimens that we collect in this arm, either patient specific or from tissue banking, or even from the Department of Pathology, FFPE, where we upfront characterize them, extract DNA and RNA, make tissue microarrays, and providing them as a resource which reduces barriers of research. More about that soon, and will follow, as well as link this material to data, clinical data that comes primarily from the tumor registry, but to a lesser extent from other sources. And we provide HIMC services, and this will, Ben Izar will talk, but broadly speaking, allows for single cell, single nuclear, and spatial multi-omics, including everything from single cell and single nuclear RNA-seq using 10x chromium technology, Genomics also provide spatial transcriptomics using Visium and Visium HD, provide spatial nucleic acid and protein imaging, and multiplex IF up to 8. More of that through the Akoya Perkin-Elmer Affinity Imager will be details about that will be provided by Ben. All of these services are provided in an integrated manner, in that you don't need to have a laboratory. You can start with a cohort and a hypothesis, and carry much of your experiments from tissue acquisition, processing, characterization, and multi-omic studies on these, and we provided data for analysis. Now, these are the services that I mentioned are listed here. And the only thing that I would add here is that is this notion that we provide a lot of project management services. This is this idea that we offer really multiple both advice and material and data that support and all kinds of services that allow for sort of full cycle management of a project. Now, a few words about tissue banking operations that we have, because there's a lot of interest in tissue acquisition. This is the starting point frequently for most of the work that we do. So the tumor bank is, as I mentioned to you, is a population sort of bank. And I say that in the sense that it's not a particular patient may not be captured depending upon the circumstances, but we capture tumor normal pairs of all available masses that are surgically removed at Columbia University Medical Center from the operating room. We barcode them, we store them, we annotate them, we reduce diagnose them. Frequently, a case may have dozens of diagnoses, and we net it out as though this is an adenocarcinoma of lung or breast cancer or sarcoma or what have you. Keep it in a database that contain all this information, including annotating the pathology reports and demographics data that may be available. We have information about which of these cases, so most of these are collected really on clinical grounds, as this bank is a CLIA approved a bank, which means that material that's collected in this environment can be used in the present or the future for clinical purposes, should a new diagnostic molecular test or non-molecular test requiring frozen tissue is needed. So this has a great deal of advantage. It operates under an IRB, and it we have a New York license to run, a New York State license to run tissue bank, and it has a bioaccess committee. On the scale wise, we have about 43,000 tumor normal pairs, 123,000 blocks in some 13 freezers. And here we see the distribution, either in the pie chart or in this list, of the type of tumors and tissues that we have. And as one might imagine, we have what is commonly operated on is what we have. In addition to this, we have tissues that do not come, much less frequently, from the operating room. That is tissues that are primarily on a biopsy level, whether it's from IR, in conventional radiology, or endoscopy, colonic or esophageal or gastric, some endoscopic biopsies, or cystoscopies from genitourinary pathology, or for that matter, bedside. So the latter are generally are a part of what we call the patient-specific or project-specific or trial-specific banking. Normally, you're not allowed to collect a tissue specifically for freezing or other activities in the setting of biopsies without patient consent, and this is what this achieves. So this type of banking basically allows the researchers to define, it's like a bespoke banking, that a particular patient will be collected, a priority of what is to be collected, and the methodology of collection, whether you want formalin-fixed tissue, frozen tissue, fresh tissue for organoid, single cells for patient-derived xenografts, for vaccine, ex vivo drug testing, or whatever else that you want. And this is generally accomplished by sending us an email that states who the patient is, when the procedures are, and what the priority and processing that's required, and then the destination. And we would typically call you to pick up that sort of specimen. Frequently, as a part of this, the bank acts not necessarily as a bank, but as a procurement agent without actually storing anything. Many of the stuff in this that's a product of this patient-specific banking remains in our bank, but occasionally, particularly all the fresh tissue, goes immediately out to the various laboratories for organoid, single-cell vaccine, PDXs, and so forth. The big advantage in this is that you can ask for a specific patient to be collected, so you can ensure that tissue is collected. You can define exactly how you want it to be processed and where it should be destined. And also it expands the collection location from operating rooms to these various peripheral sites that I mentioned, IR, endoscopy, cystoscopy, bedside. And this occurs throughout the day. And this supports a variety of initiatives like phase 1 trials, precision oncology initiative, the N of 1 project of Califano, Dr. Shen's work on prostate and GU, Olive from the Optic Lab, and a variety of others. This is done by sending us this form, which is provides us the information that's required about who to collect, when to collect, where the collection is, what the priority of the collection is, because sometimes, particularly in this biopsy setting, there's not enough material. The operation might stop in the middle of it. And so following clinical collection, let's say 3 cores of tissue are collected from a liver biopsy, 1 core, and then additional cores are needed for research. And they can only fulfill 1 or 2 of them. And this prioritization provides you the capacity to prioritize their collection, define the processing, and then define the destination. These type of collections have to be done under IRB and patient consent, and that process exists. Now, I mentioned before that we have something called next generation banking, this third arm of banking that exists beyond traditional banking and the bespoke banking we just saw. The next generation banking is a systematic evaluation. So everyone has frequently in large centers, there's tissues, but those tissues are collected primarily on the basis of prior history or radiology or the presence of a gross mass. But you don't necessarily know what you captured. You've frozen them, you kept it in the bank. When somebody wants to do a study, you have to start from beginning of defining some cohort, and then finding if for that cohort is present either, let's say if you need a frozen environment, frozen tissue, and then you have to pull out the specimens that are frozen and determine whether that material actually contained tumor material or does not, and what their purity and viability is, and quantity. So for all of those reasons, by having a bank which systematically evaluates tumors, either on the organ basis, breast, pancreas, and lymphoma are the 3 types that we have, or on a project basis, you can reduce barriers to research. You can make it non-proprietary. You can make it large scale. It's off the shelf. These are highly characterized. RNA, DNA is available immediately. So it's this type of analytes that more commonly are used. So this can enable and accelerate research. And not only that, it does that, it also allows for collaboration on the same material. So this is our next generation sort of banking platform viewed from sort of a data perspective. All the physical elements that we might have are listed in our specialized database that we created to support this activity, including whether we have paraffin tissue, frozen tissue, whether we have off-the-shelf DNA, RNA, cDNA, tissue microarray, whatever that needed. The database contains information about where these specimens come from, whether they're primary, recurrence, or metastasis. They collect pathological information and to some extent clinical information, particularly from the tumor registry, although additional information can be collected from specific clinical research databases or from EPIC data warehouse. And the whole idea is that you can come to us instead of starting from scratch and say, I would like to define a population, let's say 100 cases of African American who are, let's say, premenopausal women with triple negative breast carcinoma. Give me 100 nanograms of RNA, and then we give it to you. And you then can send it to any one of the shared resource or even to outside companies to do biomarker analysis, and then utilize the clinical information that we collected to accelerate research. Now, this was originally built for P10 discovery many, many years ago, decades ago, but it could be used for anything. And this same platform can be used as a collaborative platform, either prospectively or retrospectively, in that, let's say someone did mutational analysis or transcriptomic analysis on a cohort of patients, and somebody else can come and, if they're interested in a similar cohort, then discuss collaboration with, so let's say they might want to do a genomic analysis, somebody else did transcriptomic or did bulk transcriptomic versus single cell. All of that can be now done on the same specimen, and so you don't have to repeat it, and it provides a lot of efficiency for research. In essence, this macromolecule banks is the convergence of clinicians, pathologists, researchers, biostatistician, bioinformatician. Any one of these may play more than one role onto the macromolecule bank, and they could collaborate in real time or retrospectively. As an example, we have a large pancreatic tumor bank with a whole variety of tumors, some 792 adenocarcinomas, but we also have 146 pancreatic endocrine tumors, benign neoplasm, a variety that could be used for research. And we have data about which specimens we have DNA on, RNA, the quality of the RNA and the DNA. And that's been frequently used by a variety of research. That's been used by a variety of research to either use this material or use the information that we got from this material about the diagnosis, the quantity, and the quality to do their own analysis. And here, this sort of covers the analysis that the tumors that we analyzed, placed in the breast bank, which we reviewed some 3,300 tumors, pancreas, some greater than 1,500 tumors, and some about 600, almost 700 lymphomas. And they've been used by various researchers at various times to support research. Now, our work in the next generation banking is not exclusive to frozen tissue, although much of what I showed you up at the now is related to that, but also about cohort that may have been defined on a project level in formalin-fixed paraffin-embedded tissue. So we have all kinds of smaller cohorts in this collection. Now, I just want to cover just a few points about how you access some of our services. So, particularly for an investigator who has defined a hypothesis, who now is interested in defining a cohort that is necessary to interrogate that hypothesis, fundamentally, you have to divide the question. If you're interested in material, tissues, and whether blood, primarily tissues, but also whether there's blood or urine or other liquids, whether this is a sort of a retrospective analysis of tissues that have been already collected or prospective analysis. Typically, cohort, the first, so beyond the hypothesis generation, the first element is to define a cohort. And that cohort may be defined either by the DBSR or by CUB, the Columbia University Biobank, or by CUB. And most cohorts have now been largely defined so far by DBSR. Some things may transition, where they can define through EPIC what's available, including based on whatever parameters that you give them, demographic, clinical data, stage, disease type, and so forth. And then check whether there are frozen tissue and whether there are liquids that are available in the system. And then direct you to the specific resource that contains that material. And that could be the beginning part, should you want to enter into our system into some processing or characterization. In the prospective arm, similar process occurs in which you can in real time, prior to procedures defined through Epic generally, patients who undergo particular procedures with particular diagnosis and demographics data, and that can be used therefore to incorporate them into the so-called bespoke or project-specific or patient-specific banking procedures, where patient will be consented and request will be made of the bank to collect, and the surgeon to facilitate the collection of the material that's required, which are prioritized with whatever processing that you want. And that will be the beginning material for, that will be the acquisition on for the project, and may involve sending out the tissue to biospecimen, a part of some trial, or it may involve to the sponsor, or it may involve further processing and characterization in-house. Just want to make just a few points about IRB and IRB guidelines. So in general, any tissues that are linked to identifiers require an IRB. The bank can act as an honest broker and de-identify specimens for you. One thing to remember, that if you're going to do any large-scale sequencing, DNA or RNA, you have to follow the NIH genomic data sharing policies and consent policies, which require that there'll be patient consent, specific patient consent for the processing and sharing of the data respectively. And that in that instance, this can be a barrier in part using our material, because in large measure, a large portion of the specimen that we have collected and frozen were collected on the clinical grounds, and now are asked to be accessed for research purposes. In those instances, we'll have to, so any specimen that was collected prior to 2015 can be used without consent. Any specimen that is been collected after 2015 needs a consent unless the patient is deceased, in which case it does not need a consent. And then we could use, we have records to determine whether the DBSR or CUB have consented them. If not, they can consent them. It's not as, the latter part is not as easy as, but this is one of the things that we need to choose when in choosing specimens from our system, depending upon what it is that you intend to do and whether you require consent. There are some exceptions to the idea that we can de-identify specimens, and that includes if bank personnel are associated with the project, on the project, then you cannot. And that includes whether, as I mentioned to you about this sequencing, either RNA or DNA, that requires consent, as well as if the sponsor that is dealing with this project requires consent, and a variety of other circumstances. So just broadly, a typical cohort project requires that you first define, beyond the hypothesis, the cohort that you want through DBSR or CUB, and then they will check with the bank about the availability and the Department of Pathology of frozen tissue or formalin fixed and paraffin embedded tissue. Then that material will have to be extracted from the Department of Pathology if it's in the case of FFPE. And the slides and blocks of those cases are requested. They are delivered to the MPSR only. They have to stay within the realm of sort of pathology. And then through MPSR, key slide identification and block identification is made, and then a decision by the investigators to what they want, whether they want immunoblanks, or they want PCR tubes, or they want microdissection, or they want tissue microarray or digitalization, or whatever else that's required. I'll just broadly conclude by saying that we serve as a very large group of 336 PIs, 809 users, supporting some 669 grants, 61 IRBs last year. We provided close to 500,000 granular services and 6,700 baskets of requests. That these baskets of requests mean, pile up multiple requests. And about 130 requests a week that we we fulfill. And we support all kinds of programs, including the TCGA, early onset malignancy, NCI patient-derived models. This is fresh tissue collection for NCI for PDX development and so forth. And lastly, we supported some 250 manuscripts, at least, many of them more than 50% of high impact. Any questions?